Hello guys, welcome to our next chapter, chapter number 6, which is the continuation of our pulmonology topic. And this will be going over everything related to pulmonary embolism and DVT. So the reason I've put these both together because obviously both of them go hand in hand always. Whether if it's a patient that had a prolonged surgery and they develop shortness of breath and pain in the lower leg, it's going to be DVT and pulmonary embolism. So we have to always consider these points, these two pathologies together. And because of that, the treatment, the investigations, the classification for these two is always going to be similar, right? Now to start off with pulmonary embolism, it is the third most common cause of cardiovascular death after MI and stroke, and it occurs when the thrombus, usually from DVT, occludes the pulmonary arterial system. And the AMC is going to test the risk stratification, investigation, and management, including what is the thrombolysis decision that we'll be making. And later on in this next section, we'll be going over, how do we deal with the different types of PEs, ones that are massive, submassive, and non-massive. Now to start off, we'll be going over, so Virchow's triad says that there is stasis, that means prolonged immobility, heart failure and stroke, hypercoagulability, such as malignancy, such as Trousseau syndrome, pregnancy, OCPs, thrombophilia, especially factor V Leiden, and protein CS deficiency, antiphospholipid syndrome, and dehydration, and endothelial damage, such as in trauma, surgery, central venous catheters. Now this is an important one because in central venous catheters we can also have infections. Then also vasculitis. Now, why is the Wells score used? The Wells score is used so that we can see the probability for the patient to be developing a PE later on. All right, and if the Wells score is less than or equal to 4, then the probability is low. So we use D-dimer first, and if it's negative, then PE is excluded. If it's positive, then we do from D-dimer we move on to CTPA, right? However, if the Wells score is high, we directly do CTPA and we skip the D-dimer test. Now, what is the criterion for Wells? Firstly, is going to be clinical symptoms and symptoms of DVT, so leg swelling, pain on deep palpation, so that's 3 points. Then alternative diagnosis less likely than PE, 3 points. Heart rate that is high, so more than 100 beats per minute, that's 1.5. Immobilization for more than 3 days or surgery in the last 4 weeks, 1.5. Previous DVT or PE, 1.5. Hemoptysis, 1 point, and malignancy such as active treatment within 6 months or palliative, 1 point, right? Now CTPA versus VQ scan decision. So these are a lot of the questions have come, especially in the March 2026 recalls, and a lot of the questions that I've done from the last year's recalls as well, they had CTPA versus VQ scan. So what is the situation and which do we choose? And what is the reason for that? So the first one is going to be standard presentation, no contraindications. We do CTPA, CT pulmonary angiography, that's going to be first line. The reason is that it's rapid, high sensitivity, specificity, and also diagnosis alternatives such as pneumonia, aortic dissection, and is the gold standard. So CTPA, the best one if there are no contraindications. If it's a pregnant patient, we move on to VQ scan, and this is preferred over CTPA. CTPA because it has higher radiation to breast tissue, and VQ has lower fetal and breast dose, and if VQ scan is non-diagnosis, then we do CTPA. Then if the patient has chronic kidney disease, again we do VQ because CTPA requires iodated contrast, which is nephrotoxic, and allergic risk is high, and with VQ we avoid contrast. If the patient already has a pre-existing lung disease, COPD or fibrosis, we do CTPA because VQ is unreliable for these patients with abnormal lung parenchyma. So we have false positives in these patients. If a patient has normal chest X-ray, we can do either VQ, which is more interpretable with normal chest X-ray. All right. If the patient has a normal chest X-ray, VQ is better because it's better to be interpreted, and we always use something that has lower radioactive dosage. All right. Now, if the patient is hemodynamically unstable, especially if they have massive PE, we do a bedside echo or CTPA if the patient is stable enough. All right, bedside echo for RV strain and CTPA if the patient can be moved. Now, the important is that in AMC's March 2026 recall specifically flagged the CTPA versus VQ decision tree. And the key rule is that CTPA is for the first line in most adult patients. VQ is preferred in pregnancy and CKD. All right, 2 scenarios where it's preferred. And do not give CTPA without contrast to a pregnant woman unless absolutely necessary. All right. Now moving on to the different types of PEs, which is the massive PE versus the submassive PE versus non-massive. Massive PE means that the person is going to be hemodynamically unstable as BP is going to be less than 90 mmHg. They need vasopressors or are at cardiac arrest. Hemodynamics unstable. The treatment for this is going to be systemic thrombolysis if no contraindications, surgical embolectomy if thrombolysis fails, and anticoagulate immediately. All right. Now this is important because we do TPA, right? If there is no contraindications, then we move on to surgery. If this thromboembolysis failed, and we have to do anticoagulation immediately. Now, if the patient has just a submassive PE where they are normotensive, but right ventricular dysfunction can be seen through echo or CTPA plus elevated troponin and BNP, which means that they are going into ischemia, cardiac ischemia. Hemodynamic are stable, but they are at risk of going into unstable. In this, we do unfractionated heparin anticoagulation. We consider thromboembolysis for deteriorating submassive PE, and we do catheter-directed thrombolysis options. We need to keep them open in case of the deterioration of the patient. All right. First line, unfractionated heparin and anticoagulation. Now, in non-massive PE, patient is normotensive and no right ventricular dysfunction is seen and normal biomarkers. Patient is stable and they're not at risk of going into submassive or massive or deteriorating further. So in this, we just give them DOACs. All right. And discharge of low score, that means PESI score is less than 1 or equal to 1. All right. Now moving on to the important trap that the AMC will set is systemic thrombolysis, TPA in massive PE. And we have to know the indication, the agent that's used, absolute contraindication, relative contraindication. After thrombolysis, what do we do? Thrombolysis, what do we do? So indication is going to be hemodynamically unstable PE where the SBP is less than 90 mmHg or there's cardiac arrest with no absolute contraindication. Agent is alteplase IV over 2 hours. All right. Then absolute contraindication is going to be prior intracranial hemorrhage, recent less than 3 months ischemic stroke, and structural CNS diseases, recent or less than 3 month heterospinal surgery, active bleeding or aortic dissection. Relative contraindication is recent surgery in less than 2 weeks ago, recent non-CNS trauma, severe uncontrolled hypertension, pregnancy, active peptic ulcers, and anticoagulations. Now, these are relative contraindications because in these patients we have to weigh in the benefit versus the risk and proceed forward. Now after thromboembolysis, we have to start heparin when APTT is less than 80 seconds after thrombolysis window. So if thrombolysis fails or is contraindicated, surgical pulmonary embolectomy should be done. All right. Now moving on to anticoagulation protocol. Now the provoked PE, that means it's reversible and the cause of it was reversible, example surgery or flight, we do DOACs, rivaroxaban 2 times daily for 21 days, then 20 mg. So this is the doses, and they sometimes ask the doses, but I haven't seen a lot of questions. What I've seen are the drugs and the duration of them. All right. Then unprovoked PE, where we don't have any causes that we can identify. DOAC is going to be preferred, and we add an warfarin where the INR is 2 to 3 if DOACs are contraindicated. All right. Now the minimum duration is going to be 3 to 6 months and consider indefinite if there is high risk for recurrency. And we have to evaluate thrombophilia and malignancy screening before we start the regimen for these patients. Now, if the patient has a PE plus an active malignancy, then we give them low molecular weight heparin or enoxaparin. And right now, we also give them DOACs. They are more preferred now. Low molecular heparin used to be preferred back then, but now we prefer DOACs again. So, unprovoked PE with active malignancy, we prefer DOACs. All right. And we give them as long as there is a duration of the malignancy activity. All right. Now, DOACs are preferred over LMWH in cancer, except for GI and GU cancer, where bleeding risk is high. All right. Now, PE with pregnancy, we prefer low molecular weight heparin throughout pregnancy plus 6 weeks postpartum. All right. The DOACs are contraindicated in pregnancy. So if it's contraindicated, we obviously give them low molecular weight heparin. because DOACs are teratogenic and they can cross into the placenta. Now, warfarin is teratogenic in the first trimester. All right. Now, if the patient has a massive PE, we give them UFH or unfractionated heparin as initial anticoagulation during or after thrombolysis, and then we transition to DOAC or warfarin when hemodynamically stable. All right. And the important point is that unfractionated heparin can be reversed with protamine sulfate if there is bleeding. All right. Now, moving on to deep vein thrombosis. The presentation it's very common now. You should know this if you have already graduated and are practicing. Is that there's going to be unilateral calf or leg swelling, erythema, warmth, tenderness along deep vein system, and Homan sign where there is calf pain on dorsiflexion. And this is, according to Murtagh, it's unreliable and not recommended. But still, they could say that the Homan sign was positive. So important that you know this. Alright, diagnosis is through compressive ultrasound, and this is the gold standard for proximal DVT. If ultrasound is negative but there is high suspicion, we repeat the ultrasound in 5 to 7 days, or we do a D-dimer test. Alright, now Wells DVT score is going to be active cancer is 1, paralysis or recent immobilization is 1, bedridden for more than 3 days or bedridden for more than 3 days and surgery less than 4 weeks ago is going to be 1, localized tenderness is 1, entire leg swollen is 1, calf swelling more than 3 centimeters is 1, pitting edema is 1. So most of these are 1. So collateral vein is 1, previous DVT is 1, alternative diagnosis equally more likely is 2, and more than 2 is going to be likely DVT. A score more than or equal to is likely DVT. All right. Treatment anticoagulation same as PE. DOACs are first line. Then duration is provoked as 3 months, unprovoked as 3 to 6 months. Complication, PE is the most feared complication of DVT. Post-thrombotic syndrome, which is due to chronic venous insufficiency, skin changes, ulcers, ischemic product is going to be formed, and they could leak into the system, and that is chronic venous insufficiency. Then special scenarios where there is distal calf DVT, we anticoagulate if symptomatic, or proximal propagation on serial ultrasound, and superficial thrombophlebitis. For superficial thrombophlebitis, we use NSAIDs, fondaparinux if extensive and near saphenofemoral junction. So these are 3 different drugs that we use because of 3 different investigations and drugs because of the different scenarios. So we use superficial thrombophlebitis, we use NSAIDs. If fondaparinux if there is extensive or near saphenofemoral junction. Then if it's a calf DVT, we use anticoagulation if asymptomatic or proximal propagation on serial ultrasound. All right. Now moving on to the ECG and PE, this is the most important pattern, which is S1Q3T3. Sinus tachycardia is going to be most common. ECG finding in PE simply responds to hypoxia, most common. Then S1Q3T3 is S wave in lead 1, Q wave in lead 3, and T wave inversion in lead 3. Classic, but it's relatively uncommon and indicates acute right heart strain. It's in about 20% of PE cases. Now RBB, it's acute right ventricular pressure overload causing conduction delay. It's in 25% of massive PE. And in RBBB or RBB, you get excess deviation. That's how you know it's RBB. Now T wave inversion in lead V1 to V4 because of right ventricular strain pattern, poor right ventricular function. It's in common in massive PE. Right, P pulmonale, which is peaked P waves in lead number 2, reflects right atrial dilation from right ventricular strain, which is again uncommon, but it could be seen. Normal ECG does not exclude PE because it's normal in about 20% of patients. Now the for the resource for PE pattern is so the link is given here, you guys can check it out. And the AMC Measure and ECG with S1Q3T3 in patients with pleuritic chest pain and dyspnea. The answer is PE, not MI. All right, because S1Q3T3 is known for PEs. All right. Now these are the questions. I think the questions are really just 2 questions for this section because this was a very small section. And this is a pretty short video for today. It's just the 6th chapter, and from the next chapter we'll be moving on to the neurology section. If you guys have any questions, just let me know. The Telegram group link and the WhatsApp group link is going to be in the description. You guys can check out this guidebook chapter. The Google Drive link is linked in the pinned comment section. If you guys have any questions, suggestion, any queries, just for this chapter, for the previous chapters, feel free to let me know in the comment section below. Hope you guys have a good day. Thanks for watching.